طبعا نرحب بحضراتكم جميعا. كنت اتمنى ان العدد يبقى اكبر من كده، بس يعني نتمنى ان الناس join us يعني as soon as possible. We will start with the contemporary management of heart failure. We know that heart failure is a common disease. It affects 1 to 2% of the general population. It increase due to the increasing age, the increasing risk factors, improving survival for patients with coronary artery disease. So what is the definition for heart failure? According to the last definition, which is Universal Definition and Classification of Heart Failure, which had been published this year by the Heart Failure Association, the American Heart Failure Society, and the Japanese Heart Failure Society. We standardized the definition to be symptoms and or signs of heart failure caused by structural and or functional cardiac abnormality and incorporated by at least one of the following: high level of biomarker in the form of natriuretic peptide, NT-proBNP, or objective evidence of cardiogenic pulmonary or systemic congestion. So symptoms and or signs caused by structural and or functional cardiac abnormality. These abnormalities can be seen by echo in the form of low ejection fraction, abnormal cardiac chamber enlargement, E over A prime more than 15, moderate to severe ventricular hypertrophy, or moderate to severe valvular obstruction or regurgitation. In addition to the high level of natriuretic peptides, the objective evidence of cardiogenic pulmonary or systemic congestion can be identified by many imaging modalities, such as chest X-ray, elevated filling pressure by echo, hemodynamic measurements by right side heart cath, pulmonary artery catheter at rest or with provocation. So the universal definition classified stages of heart failure into 4 stages. Patients who are at risk for heart failure, stage A, they have no symptoms or signs of heart failure, current or previous, without structural, biomarker, or genetic markers for heart disease. But they have risk factors for heart failure, like hypertension, cardiovascular disease, diabetes, obesity, exposure to cardiotoxic drugs, family history of cardiomyopathy. Stage B, which is pre-heart failure, they are patients without failure symptoms or signs, but have an evidence of one of the following: structural heart disease like left ventricular hypertrophy, chamber enlargement, wall motion abnormalities, myocardial abnormality, valvular heart disease. Abnormal cardiac function like low ejection fraction, left ventricular or right ventricular, high filling pressures, normal diastolic function, in addition to high level of natriuretic peptides or elevated troponins in patients who are receiving cardiotoxic drugs. While heart failure stage C, who are patients with current or previous symptoms and or signs of heart failure caused by structural and or functional cardiac abnormality. The heart failure symptoms may improve, so we will call it as heart failure in remission, or patients have persistent symptoms and signs of heart failure. At the end of the journey, for heart failure patients, we might see advanced heart failure, stage D, patients having symptoms and or signs of heart failure at rest, recurrent hospitalization, despite using guideline-directed medical therapy. They are refractory or intolerant to heart failure medications. So they require advanced therapies and referral for specialized centers for considering left ventricular assist devices or transplantation. So in this universal definition, we have 4 categories for heart failure classification: Heart failure with a reduced ejection fraction if the EF 40% or less. Heart failure with preserved ejection fraction, 50 or more ejection fraction. In the gray zone, 41 to 49, this is known as heart failure with mildly reduced ejection fraction. And the new phenotype, which is heart failure with improved ejection fraction. When we have patients having heart failure with baseline ejection fraction 40% or less, and improved by 10 points or more ejection fraction, starting, for example, from 35, now it is 48, for example. And the second measurements of the ejection fraction should be more than 40%. This is heart failure with improved ejection fraction. We know that heart failure, a disease which is associated with neurohormonal activation. After myocardial damage like post-MI, for example, there is an activation of neurohormonal system, activation of the renin-angiotensin-aldosterone system, sympathetic system, arginine, vasopressin, endothelin. At the initial stage, they are compensatory to maintain cardiac output, but at the long term, they have a deleterious effect. They will induce saltwater retention. They induce vasoconstriction, which will lead to decreased forward stroke volume and decreased cardiac output. So the vicious cycle will continue in the form of increased preload and afterload, high feeling pressures, symptoms and signs of heart failure, and symptoms or signs of low cardiac output. So in heart failure patients, we are giving the treatment to improve the clinical status of patients with heart failure and to improve the functional capacity and quality of life and to prevent hospitalization and to improve survival. So for any heart failure drugs, we are looking for a drug which improves symptoms, improve quality of life, prolong survival, and decrease hospitalization. This is the ideal parameters which should be considered for any new drug class. So to do that, we have to counteract the deleterious effects of many pathways involved in heart failure. We have to counteract the renin-angiotensin-aldosterone system. So we have ACE inhibitor, ARBs, ARNI, aldosterone antagonists. We have to block the sympathetic system by the use of beta blockers and to preserve the endogenous natriuretic peptides by using the sacubitril, valsartan, or ARNI, and to decrease heart rate using ivabradine in addition to beta blocker. And for some patients, we might need the combination of hydralazine, azorbide, nitrate, balanced vasodilation, and oxidative stress modulation, like in African Americans. And prevention of sudden death is important. So we have to consider the implantation of ICD. And in patients having electrical and or mechanical dyssynchrony, cardiac resynchronization, which improve the outcome for patients with heart failure regarding symptoms, quality of life, remodeling, and prevention of sudden death. Congestion can be treated with the use of diuretics and improving exercise capacity by rehabilitation and exercise programs. So let us summarize the key points for drugs used for treatment of heart failure. We have diuretics to relieve congestion. Unfortunately, they can activate the sympathetic nervous system and the renin-angiotensin-aldosterone system. So use the lowest doses to maintain evolemia. Don't aggressively use diuretics. Diuretics have not been shown to improve mortality. And diuretic resistance is most commonly seen, especially in advanced heart failure, due to poor oral bioavailability of the drug, compensatory distal tubular sodium reabsorption, and renal insufficiency. Thiazides and aldosterone antagonists should be given before loop diuretics. Don't forget concomitant sodium restriction. 2016 guidelines recommended life-saving drugs for any patients with heart failure with reduced ejection fraction. According to the evidence from many clinical trials, ACE inhibitors is recommended in addition to beta blocker and MRA to reduce mortality and hospitalization. The same for beta blocker and the same for MRA. All these drugs are considered class 1A recommendation. So this slide summarizes the reduction in mortality achieved with the use of angiotensin receptor blocker, a relative risk reduction 12%, with ACE inhibitor 16%, with beta blocker either bisoprolol, metoprolol, or carvedilol 34%. And in RAS trial for spironolactone or the use of eplerenone in emphasis heart failure, 30% reduction in mortality have been achieved. What about ACE inhibitors? ACE inhibitors improve symptoms, clinical status, and the exercise capacity. It improves cardiac function. It reduces hospitalization. It has a favorable effect on remodeling, and it prolongs survival, reduce vascular events as detected in some studies like HOPE trial. So ACE inhibitor should be given for all heart failure patients with ejection fraction 40% or less. We have to use the target doses used in clinical trials. Don't use small doses, many doses. We have to titrate the dose to reach to the tolerable target dose. Intolerance due to cardiorenal limitations is associated with poor prognosis. We have seen side effects in the form of cough in 15% of patients receiving this inhibitor, angioedema in rare cases, and increased creatinine is expected in up to 0.5 milligram per deciliter, 30% increase initially due to decrease in the intracranial pressure, but we have to continue the medications and follow up the kidney function, creatinine and potassium. Most studies have excluded patients when having serum creatinine more than 2.5 milligram per deciliter. Beta blockers now are considered cornerstone for treatment of patients with heart failure. The rationale for using beta blockers in heart failure is based on that in heart failure patients, we know that there is increased sympathetic nervous system activity. And the deleterious effects of catecholamine stimulation, it increased myocardial oxygen demand and ischemia. It increased oxidative stress. It has a deleterious effect on remodeling, and it can precipitate several forms of arrhythmias, especially ventricular arrhythmias. The toxic effects of norepinephrine on the myocytes, leading to myocyte necrosis or apoptosis. And in heart failure patients, there is a down regulation of beta-1 receptors. So with the use of beta blockers, this will lead to upregulation of beta receptors in myocytes. The use of beta blockers will lead to decreased myocardial oxygen requirements. It has an anti-arrhythmic effect, improve myocardial relaxation, decrease heart rate, protection against circulating catecholamines, correct the overactivated RAS system, and reduction in incidence of acute coronary events, in addition to reduction in sudden death. Sudden death is common in heart failure. It is responsible for 50% of mortality, and beta blockers, one of the drugs which decrease sudden death. So beta blocker should be given in any patients having EF 40% or less, symptomatic or asymptomatic. We have to use the agents, bisoprolol, metoprolol, or carvedilol, and the target doses used in clinical trials should be initiated when the patient is evolemic. Don't start beta blockers when the patient's having evidence of congestion, because this can precipitate acute decompensated heart failure. Patients should be off intravenous vasoactive agents, and it's preferred to start the drug in hospital in patients hospitalized for acute decompensated heart failure to test the tolerance of the drug, then titration every 2 to 4 weeks, as long as the patient is stable. So you have to monitor your patients clinically for evidence of congestion, and you have to monitor your patients for blood pressure, heart rate to avoid the risk for bradycardia, and weight gain in patients having decompensated heart failure In acute decompensated heart failure, we can usually treat patients without changing beta blocker doses, just increasing dose of diuretics, except that if the patients have an evidence of hypotension and hypoperfusion, so beta blockers should be stopped. Aldosterone antagonist is another pathway, is very important because we know that the deleterious effects of aldosterone in patients with heart failure. Aldosterone is responsible for increased myocardial fibrosis. It has a role in the ventricular arrhythmias, and aldosterone antagonists have been proved to improve the outcome in patients having heart failure with ejection fraction less than 40%. Potassium and renal function should be assessed regularly and contraindicated when patients having hyperkalemia above 5 or advanced renal insufficiency greater than more than 2.5. Hyperkalemia is very common phenomena seen during treatment patients with heart failure. Hyperkalemia can be classified as mild hyperkalemia 5 to 5.5, moderate hyperkalemia 5.5 to 6, and more than 6. This is a severe hyperkalemia, which might be a life-threatening condition predisposing to ventricular arrhythmias and sudden death. So be very cautiously in elderly diabetic patients and some drugs which carry increasing the risk for hyperkalemia. Consider eplerenone post myocardial infarction, and in those who have side effects like breast pain or gynecomastia with the use of spironolactone. We know the use of sacubitril valsartan or ARNI, which have been proved in a very big trial paradigm heart failure study, which included around 8,000 patients having heart failure function class 2 to 4. And when randomized to receive sacubitril valsartan in a target dose 200 milligram PID, compared with the cornerstone of treatment, which is enalapril, this was associated with statistically significant reduction in the primary endpoint, cardiovascular death or heart failure hospitalization. And the number needed to treat to prevent this primary endpoint was 21 patients. Recently, we have a new drug class, which changed the new guidelines, which is sodium glucose co-transport inhibitor. Drugs act on the SGL2 protein in the proximal renal tubules to block the reabsorption of glucose. So it will induce glycosuria as well as natriuresis. And this osmotic diuresis will lead to decrease preload, afterload, and reduction in LV wall stress, reduction in the interstitial edema, and improving kidney function and the cardiorenal physiology. And this was based on 2 landmark trials. Dapagliflozin in heart failure, which is DAPA-HF trial, a trial which included 4,744 patients with and without diabetes, having ejection fraction less than 40%, NEAF function class 2 to 4, high levels of NT-proBNP, up to a GFR of 30 milli per minute, excluding patients having low blood pressure less than 95 or patients having type 1 diabetes. And interestingly, only 45% of those patients have type 2 diabetes. If we look for comparison with the standard of care treatment, patients who received dapagliflozin 10 milligram per day were associated with a significant reduction in the primary endpoint, which was cardiovascular death or worsening of heart failure event. A relative risk reduction, 26%, and the number needed to treat was 21 patients. The same have been proved with the use of empagliflozin in Emperor reduced trial, a trial which included 3,730 patients having ejection fraction less than 40%, and the same randomized to receive empagliflozin 10 milligram per day versus placebo in heart failure patients function class 2 to 4. And they looked for the primary endpoint, which is time to first event of adjudicated cardiovascular death or heart failure hospitalization, and the secondary endpoints, which is first and recurrent adjudicated heart failure event. And in addition, the slope of a change in the estimated GFR, looking for the decline in GFR with the use of the drug compared with placebo. And the same observation, the same benefit of using SGLT2 inhibitor have been proved with the use of empagliflozin regarding the first adjudicated cardiovascular death and hospitalization for heart failure decreased significantly compared with placebo. A relative risk reduction 25%, absolute risk reduction 5.2%. The number needed to treat was 19. Very significant effect. And interestingly, the benefit have been appeared very earlier. We can see the divergence of the two curves started too earlier, within 28 days in DABA-HF, and the same here. This indicates a favorable hemodynamic effect for the SGLT2 inhibitors in reduction of the filling pressure preload, and this is responsible for the great benefit that have been seen with these two drugs. So we have now 4 drugs, 4 pillars, fantastic 4, foundational therapies in heart failure, heart failure disease modifying agents, not only ACE inhibitor or ARNI, but beta blocker MRA, and the new one, which is SGLT2 inhibitor. So what about the recent guidelines, 2021, after the publication of the 2 landmark trials for the use of SGLT2 inhibitors in heart failure? The new guidelines recommended diuretics class 1C to relieve congestion in patients with heart failure and reduce ejection fraction, to alleviate symptoms, improve exercise capacity, and reduce heart failure hospitalization. When we can use angiotensin receptor blocker, we can use ARBs when patients having intolerance to ACE inhibitor or ARNI. This is class 1B recommendation. In addition, we have to use beta blocker and MRA. This is the only indication in the guidelines for the use of ARP if the patient cannot tolerate ACE inhibitor or ARNI. So look for the class 1A recommendation. Not only ACE inhibitor or beta blocker or MRA as before, but in addition, the new recommendation for the use of dapagliflozin or empagliflozin in patients with HFrEF to reduce mortality and heart failure hospitalization. Cyclopentine valsartan as a replacement for ACE inhibitor in patients with HFrEF to reduce the risk of heart failure hospitalization and death, and this is class 1B based on the evidence from Paradigm heart failure trial. Some patients of heart failure receiving the target tolerated dose of beta blocker, but still the heart rate is more than 70. And this is not good for heart failure patients. So we have to slow the heart rate. So in those patients, we can add ivabradine, which is an IF current inhibitor, inhibit the intrinsic activity of SE node. So this is class 2A recommendation. And some patients are contraindicated for beta blockers. So this is the same recommendation for the use of ivabradine, which is class 2A recommendation. A new drug have been added, which is vericiguat. Vericiguat is the soluble guanylate cyclase agonist. The rationale for the use of vericiguat is based on, in heart failure patients, there is a decrease in the nitric oxide activity. And this is responsible for activation of the pathway of guanosine triphosphate to cyclic guanosine monophosphate, which is important for myocardial function as well as for vasodilation. So due to the increased oxidative stress in heart failure patients, there is down regulation of the pathway of nitric oxide. So with the use of vericiguat, which is soluble guanylate cyclase agonist, increasing activity of cyclic guanosine monophosphate, this will lead to improving myocardial function, decrease myocardial stiffening, fibrosis. It has favorable effect on remodeling, and it improves vasodilation. So in a Victoria trial, which randomized patients to receive vericiguat compared with placebo, the use of vericiguat was associated with significant reduction in the primary endpoint, which was a cause of cardiovascular death and heart failure hospitalization. But they included patients who have worsening heart failure, patients who have recently hospitalized or have a recurrent hospitalization. So this drug should be given for patients who had worsening heart failure despite treatment with the 4 pillars. This is class 2B recommendation. Hydralazine isopropyl nitrate combination is class 2A recommendation in African American, as well as 2B recommendation in patients who cannot tolerate ACE inhibitor, ARP, or ARNI. The new phenotype, which is heart failure with mildly reduced ejection fraction, which is ejection fraction 41 to 49. The new guidelines recommended class 2B recommendation for ACE, ARP, beta blocker, MRA, as well as sacubitril valsartan, and the diuretics to relieve congestion class 1C recommendation. Device therapy, cardiac resynchronization should be considered in patients with heart failure, sinus rhythm, QRS duration more than 150 milliseconds, left bundle branch block morphology, ejection fraction less than 35%, despite optimal medical treatment in order to improve symptoms and reduce morbidity and mortality class 1B. It's class 1B if the QRS duration 130 to 149 and left bundle branch block morphology, the same criteria, ejection fraction less than 35% despite optimal medical treatment. And with the QRS more than 150 but non-left bundle branch block morphology, it's class 2A recommendation, and patients with QRS 130 to 149 and non-left bundle branch block morphology is considered a class 2B recommendation. So this interesting algorithm for management of heart failure with reduced ejection fraction, ACE inhibitor or ARNI, beta blocker, MRA, DABA or INBA, loop diuretics, and if the patient having ejection fraction less than 35%, QRS duration more than 130, he might be a candidate for CRT, CRTD, and prevention of sudden death is very important. So ICD should be considered a class 1A recommendation having ischemic etiology, while it is downgraded to be class 2E in non-ischemic etiology. This is for primary prevention of sudden death in patients with heart failure. If the patients having ejection fraction more than 35% or device therapy not indicated, if symptoms persist, consider therapies with class 2 recommendation, as mentioned before. The new guidelines stressed on the importance of screening for iron deficiency, which is common in patients with heart failure. Around 50% of patients with heart failure having iron deficiency, and the correction of iron deficiency lead to improvement of symptoms, quality of life, and decreased heart failure hospitalization. So we have to screen those patients asking for iron profile, and when the patients having the serum ferritin less than 100 nanogram per milli, or serum ferritin 100 to 299 nanogram per milli, or TSAT less than, with TSAT less than 20%, he is a candidate for intravenous ferric carboxymal dose, which is class 2A recommendation. And even in recently hospitalized patients, according to the results of a firm AHF trial, the use of intravenous ferric carboxymal dose in hospital lead to improvement of symptoms, quality of life, and decreasing the heart failure hospitalization. So don't forget to screen for iron deficiency and the correct iron deficiency in ambulatory patients as well as hospitalized patients. Again, this slide summarizes different lines of treatment that we have for patients with heart failure, starting from the core therapy, the 4 pillars, diuretics, device therapy, ICD, atrial fibrillation management, anticoagulation, coronary revascularization when needed, TAVI or surgical aortic valve replacement for patients having tight aortic stenosis, percutaneous mitral valve repair, edge-to-edge repair when patients having severe mitral regurgitation, ivabradine for controlling heart rate, ARBs as class 2B in some patients, hydralazine isopropyl nitrate combination. Advanced therapy, including assist device and transplantation, exercise rehabilitation, multidisciplinary approach is very important. Now, what about acute heart failure? Do we have any new data in the new guidelines? This is algorithm which summarize how to approach patients having acute onset of shortness of breath in the ER, having the symptoms and signs suggestive of acute heart failure. Based on history, clinical evaluation, we have to assess these patients starting with the ECG, pulse oximetry, echocardiography, laboratory investigation, biomarker is very important, NT-proBNP, chest X-ray, lung ultrasound. If the patient's having NT-proBNP more than 100, BNP more than 100, or NT-proBNP more than 300 picogram per milli, or mid-range ANP more than 120 picogram per milli. This confirms the diagnosis of acute heart failure, and echocardiography should be done immediately. If the patients have lower levels of biomarker, so the patients should be screened for other etiology. In every patient presenting to the ER with acute heart failure, we have to assess the volume status as well as signs of perfusion. So congestion in the form of pulmonary congestion or apnea, PND, or high venous pressure, positive abdominal compression test, hepatomegaly, lower edema, etc. And hypoperfusion, cold sweating extremities, oliguria, mental confusion, dizziness, narrow pulse pressure. So we will classify our patients into 4 categories. And the most complex is the cold and wet type. Patients who have high Wood pressure and high filling pressure, in addition to very low cardiac index. So this is the complex form. But the most commonly seen in the ER in patients presenting with acute heart failure, patients who are well perfused, but they are congested. So they are warm and wet. And those patients, of course, need intravenous diuretics to relieve congestion. So the management in those patients, if the patients have no hypoperfusion, loop diuretics to relieve congestion, and if not, increase diuretic doses, and or combine diuretics like metolazone. And patients who have diuretic resistance or end-stage renal failure, renal replacement therapy can be added. And in patients having a hypoperfusion, in addition to the use of loop diuretics to relieve congestion, inotropes are considered a class 2B recommendation. And if the patients still hypoperfused, the vasopressors like norepinephrine is class 2B recommendation. Persistent hypoperfusion and organ damage necessitate the use of device therapy, mechanical circulatory support, which is class 2A recommendation. Renal replacement therapy is class 2A recommendation as well. Cardiogenic shock is a very life-threatening condition, which needs an immediate management if the patient is having STEMI, acute coronary syndrome, emergency primary PCI, or surgical treatment if the patients have mechanical complication contributing to cardiogenic shock. So we have to identify and treat other specific causes. Consider oxygen, which is class 1, or ventilatory support, class 2A. Consider inotropes and the vasopressors, which is class 2B. And the early use of MCS is class 2A recommendation. If the patients improve regarding the perfusion, so weaning from inotropes, vasopressors, and or MCC is recommended, and to continue etiological treatment if needed, and the medical therapy optimization. If not improved, the mechanical circulatory support, renal replacement, and to consider palliative care. So the initial management of acute heart failure, the first step is to look for the presence or absence of cardiogenic shock and or respiratory failure, because this needs pharmacological support by the using of vasopressors and the ventilatory support, and the need for mechanical circulatory support. If there is no cardiogenic shock and or respiratory failure, we had to identify the acute etiology, acute coronary syndrome, hypertension, emergency, arrhythmias like rapid atrial fibrillation or ventricular arrhythmia, mechanical cause like papillary muscle dysfunction, ruptured papillary muscles, acute mitral regurgitation, pulmonary embolism, in addition to infections and tamponade, and treat specifically according to the cause. So these different tables summarize the new guidelines regarding treatment of acute heart failure, the need for oxygen when oxygen saturation less than 90%, PO2 less than 60, class 1C. Intubation is recommended for progressive respiratory failure in spite of using oxygen is the class 1C recommendation. Non-invasive positive pressure ventilation should be considered in patients with respiratory distress, class 2A, respiratory rate more than 25, oxygen saturation less than 90, started as soon as possible. And intravenous loop diuretics are recommended to relieve congestion and volume overload, class 1C recommendation, and the combination of loop diuretic with thiazides should be considered in patients with resistant edema who do not respond to increased loop diuretic. Class 2A recommendation, vasodilators, if the patients have blood pressure systolic more than 110, can be considered as initial therapy to improve symptoms and reduce congestion. It's class 2B recommendation. Inotropic agents, class 2B, in patients having hypoperfusion due to a low systolic blood pressure less than 90, who do not respond to standard treatment, including fluid challenge to improve peripheral perfusion and to maintain end organ function. Inotropic agents are not routinely recommended. Why? We know the bad effects of using inotropes regarding increased myocardial oxygen consumption, the arrhythmogenic effect of these drugs. So don't use it unless the patients have an evidence of hypoperfusion. Vasopressors, preferably norepinephrine, may be considered in patients with cardiogenic shock to increase blood pressure and the vital organ perfusion, which is class 2B recommendation. Thromboembolism prophylaxis is very important with the use of low molecular weight heparin, class 1A recommendation in patients not already anticoagulated and with no contraindication to anticoagulation. Why? To reduce the risk of DVT and pulmonary embolism. Routine use of opiates now is class 3, not recommended. Short-term mechanical circulatory support should be considered in patients with cardiogenic shock. Bridge to transplantation, bridge to recovery is class 2A recommendation. Intra-aortic balloon may be considered in patients with cardiogenic shock as a bridge therapy also to correct cardiogenic shock. It's class 2B recommendation, while it is not routinely recommended in patients with post-MI, which is class 3 recommendation. Thank you for your attention.